Hi, and welcome to the Center for Interdisciplinary Health Workforce Studies 2015 Fall Webinar Series that focuses on value-based care and the implications for the health workforce, particularly the nursing workforce. We are pleased to have all of you joining us for today's webinar. A few center announcements before we get started. First, we have posted second quarter RN workforce data to our website that details the most recent employment trends and data. During the second quarter of 2015, RN employment increased once again, while at the same time, employment decreased in non-hospital settings. We have just received third quarter data, and in the coming weeks, we will post what happened to RN employment. Second, we have also recently posted data detailing characteristics of the physician workforce to our website. Our analysis of recent ACS data examines trends in total full-time employment, hours worked, earnings, diversity, and work setting. We also have data on the physician assistant workforce that will be posted in the very near future. Finally, do you know someone who would benefit from receiving our newsletter updates? Please let us know or direct them to sign up for our mailing list on our website in one easy step. Please visit our website for this and more information at healthworkforcestudies.com. Now shifting to today's webinar. After our speaker concludes her presentation, we will provide 15 minutes or so for discussion. Please feel free to type any questions you have in the area designated for questions that is shown on your menu bar, and we will get to as many questions as we can. We are also recording the webinar today and will have it posted to our website. We have posted all of the previous webinars to our website, including last month's value presentation, if you missed any of our previous events. You can also find presentation slides posted within the event calendar as presenters allow. Today we have a great presentation focusing on the value-based care and implications for the nursing workforce. I would like to allow Peter Bierhaus, Center Director, to take a minute and let him introduce our speaker. Pete?
Hey, Christy. Thanks very much. Christy, as you all know, is broadcasting from our Nashville studios, and now she's pushed me out here to beautiful Bozeman, Montana, where it's a beautiful sunny day. It's windy. Winter has arrived, and all the mountaintops are covered with snow, so it's a very winterish holiday atmosphere. So before I introduce our speaker today, I wanted to just go back a little bit to where we began the fall webinar series. And Rich Lindworth, a professor of economics at the University of Colorado, got us off, got the webinar series started on value. And Rich really looked at this from an economic perspective, at sort of a theoretical and conceptual understanding of value from different points of view, from an individual's point of view, from an organizational point of view, and from a societal point of view. It was a very rich conceptual discussion that really, I think, broadened and deepened what we're really thinking about and talking about with respect to value. Now, after Rich, a couple weeks later, we had a second webinar. This was given by Olga Yakasheva, who's a professor at the University of Michigan. And Olga went right into the weeds, right down into the measurement of value, the most recent regulations affecting hospitals, and some thinking about how hospitals will use these new incentives to get at closer what value is with respect to nursing. So it was a very in-depth and critical conversation. Now, with Betty today, I suspect, but I don't know, I'm going to find out, that she's going to be somewhere in the middle, not quite up to the high-level, conceptual level of Rich, but not quite into the deep, deep weeds that Olga ventured into. So we'll find out when we hear from Betty. So let me introduce Betty Rambur, who is a professor of nursing and health policy at the University of Vermont. Now, during the 2000s, Betty served as an academic dean at the University of Vermont, and she also led the merger of the School of Nursing and the School of Health Sciences to establish the College of Nursing and Health Sciences. She was formerly the chair of the Department of Nursing at the University of Mary in Bismarck, North Dakota in the 90s. So these and other experiences build on Dr. Rambur's substantive leadership history in health policy and finance. From 1991 to 95, she led the statewide health financing reform effort in North Dakota. Dr. Rambur is a registered nurse. She received her PhD in nursing from Rush University in Chicago. She maintains an active research program focused on health services, quality, workforce, and ethics. Betty was appointed to Vermont's Green Mountain Care Board in August 2013. The 5-member Green Mountain Care Board oversees Vermont's payment and delivery reform and holds broad regulatory, innovative, and evaluative authority. So today, Betty's going to discuss the nursing workforce implications of emerging value-based payment models, and she'll also touch on some opportunities for nursing practice, education, administration, and policy. So Betty, I'm going to turn it over from our studios in Bozeman to where you're at in Vermont, and we'll talk with you a little bit later on. Betty?
Thank you so much for that nice introduction. And I just have to point out that it's not snowing here. It's actually still rather summery in Vermont. Thank you all for being here today to think with me and as we think together about this move away from fee-for-service, what nurses need to know. And I would like to mention that the Green Mountain Care Board is a quasi-judicial body. And so the ideas and thoughts presented here represent my thinking and are not necessarily held by the board writ large, although they may be. So I'd like to start by a bit of context and background. And some of you are going to be very familiar with this context and background and others less, but I'd like to start there. And then next I would like to move into discussing the various payment reform models and then close with what it means for nursing. So, context and background. What does a particular nursing intervention do? What does it cost? What difference does it make? And how do we in fact know? What can nurses do to improve the patient experience, population health, and contain cost? And why does it all matter? Well, the emerging model is going from high-cost volume healthcare to value-based healthcare. And there's clear signs that the pace is increasing. And so I'd very briefly like to touch on some of these recent events before we move to discussing an array of different payment reform models. First of all, just as a reminder, we all see the challenges with fee-for-service all the time. A common example, I'm a diabetic, say, or I go to a clinic and I'm diagnosed by my nurse practitioner or primary care provider, physician with diabetes. They do a wonderful job of getting me prescriptions. They perhaps refer me to a diabetes educator. But for whatever reason, I don't follow up and I end up in the emergency room. Or perhaps I even repeatedly end up in the emergency room. In fee-for-service, those different events and episodes are all largely revenue generating for the organization, provided it isn't under penalties of too early readmission, that type of thing. But there isn't an incentive to take a look at the overall situation of an individual and a population and understand what's really behind the outcomes that we see. So the accountability horizons are very narrow and very short-term in fee-for-service. It's the moment of the person right in front of us largely. The Affordable Care Act allowed creation of models that begin to require providers to take accountability for cost of care and outcomes of care, including downside risk, and I'll talk more about that in a bit. And regardless with what happens with the Affordable Care Act, Medicare is now adopting these models. An enormous sea change was announced in January 2015, where Medicare announced a very aggressive movement to value-based payments, 50% by 2018, which is almost tomorrow morning, and 90% of all payments linked to value by 2018. So you can see the numbers here on the screen with the intermediate step being the end of 2016, which is roughly a year away. So this is a very rapid pace. And at the end of summer, they sort of upped the ante. Accountable care organizations are voluntary. They now have bundled payments that are not voluntary. Roughly 75 areas of the country, 800 hospitals. This is bundled payments for joint replacement. And what's exciting about this is bundled payments create an incentive along the entire continuum of care. So there is one set of reimbursement for the entire continuum of care. And if you look at this slide, you can see all the places that nurses are involved. We are in key positions to be leaders. Inpatient hospitalization, you see second on the list. Well, when a patient is admitted to a hospital, it's because they need nursing care. Otherwise, they'd be an outpatient. Long-term care, hospital care, that's a lot of nursing, skilled nursing. We're even in the title of that one, home health, hospice, to name a few. So we are everywhere across the continuum of care, and our very baccalaureate entry is as a generalist. So we are in an ideal position to lead. So you can take a look to see if you're on the list or if your neighbors are on the list. And this Medicare shift is so important because they often serve as the default template for Medicaid and commercial insurance. So what Medicare does, everyone tends to follow. And this is critical because what is reimbursed grows and what is not reimbursed withers. I think of it as watering a garden or oxygen. What we feed grows. So how we pay and what we pay matters. So I like to conceptualize these along a range of most like fee-for-service to least like fee-for-service. And I start with fee-for-service because most of us have been marinated in episodic fee-for-service care since the beginning of our careers, so it's very familiar to us. And yet it has lots of challenges that these other models are attempting to address. So I will go over these each in turn and talk a little bit about some of the roles of nurses and successes. In pay-for-performance and patient-centered medical homes, the providers are accountable for outcomes, broader outcomes of care, not just the immediate provision at the moment. And then when we look at accountable care organizations, bundled payments, and global budgets, providers are accountable for outcomes and costs. And so that is an enormous transition from where we have previously been. But first, a reminder, what's wrong with fee-for-service? It fuels a more is better approach. It creates payment silos and therefore treatment silos. It fragments care. It has enormous disincentive toward coordination and integration and contributes to our inability to control cost. And frankly, the nation cannot afford for all of us baby boomers to move into old age together in an episodic fee-for-service system, particularly when there is so much data about the magnitude of overtreatment and waste in the system, reaching roughly 1/3 of what we do, and 1/3 of $1 trillion, which is where U.S. healthcare spending is roughly now, $2.9 trillion, is a lot of money. So pay for performance, I think of as fee-for-service with a little booster jet. And that little booster jet is the additional reimbursement that is given if quality targets are met. And the payment may be at individual, group, or institutional levels. Advanced primary care, patient-centered medical homes, person-centered health neighborhoods takes this a step further. And the state of Vermont started this notion roughly 10 years ago. So we have some person-centered health neighborhoods, and I'll show you in just a bit, that are really nearly a decade old and quite mature. And we have some data which will be released by CMS in early 2016, which is actually very encouraging in terms of cost and outcomes. But you can see here, instead of a Marcus Welby type physician-centric model of the past, for those of you that are old enough to remember the Marcus Welby show, this has a whole array of providers and services because there's a lot of incentive to keep people well. And you'll see on this image here that it rests on a health IT framework, health information technology framework. And depending on where the person is or the family is in their health or illness trajectory, very different kinds of services may be used. For example, SASH teams, which are support and services at home, are in housing hubs. They are community-based housing hubs for supporting elders, primarily elders, in their homes. For others, perhaps like some of your states, we have an enormous opioid challenge in the state. We have hub and spoke models for opioid management. So for some individuals or families, that may be the central piece. For another, it might be the Healthier Living Workshop, or it may be primary care. Now you can see here that it's rooted in lower acuity and complexity of services, moves to community health teams, and then of course includes advanced case management, advanced assessment, and specialty care, but that is not the foundation. Here you see examples of team members, and of course it includes physicians, nurse practitioners, and PAs, but it's in a whole array of different kinds of services and providers matched to the community need and the community configuration. This is what the network looks like in Burlington, which is our largest community, and I'm sure this one is impossible for you to really decipher, but you see all the webs of connections between services in this blueprint, which is what we call our person-centered health neighborhoods, and the hubs being the places, or the darker nodes being the ones that have the most connections. Well, because that's so difficult to see, I wanted to unpack that a little bit. It really takes a village. This is a very small community, 12,000 people. And you can see here the clients and patients in common. On the way bottom, you can probably see sustainable aging, which is linked to the wound center, Center for Wound Healing, etc. So you see the hospital plays an important role, but so does the community health team in the blueprint. Here you see information sharing, so you can see the importance of IT. Ones that you can probably pick out on the bottom, Maple Leaf Farm is a residential opioid management facility. On top we see the Alzheimer's Association next to a DO, but then again the health team and the hospital. Here are information sharing. Here is shared equipment, personnel, and facilities. These are referral networks. And here is what this small community of 12,000 web of connection looks like. So in this sort of model, what are the new, and I would say renewed roles, because these are things we really do know and should know. And are nurses more effective care managers than less expensive individuals? Do nurses, for example, organize and deliver group office visits? And I'll talk about that in a bit. Are we using data for individual and population health management, and predictive analytics goes for individual and population health management, and even more exciting, prescriptive analytics? So let me talk a little bit about that. Why is this important? Dev Culver from Maine reports that with the use of clinical data, they can predict which, with 70% accuracy, which patients would have an array of issues that you see here. Be admitted, go to the emergency department, have a stroke, as well as the cost of care. And the option with, or the opportunity with prescriptive analytics is then to intervene. If I, as a nurse working with a panel, can see the individuals who are likely to be readmitted, then it's up to me to begin to think about redesigning scenarios that prevent that readmission. When they added claims data, it increased to a whopping 90% accuracy. Now, because Bayesian statistics realize it's really pattern recognition, more rare events like deaths, which is more rare than the population being diagnosed with diabetes, it was only 30%. But even with that, they were able to do things like starting hospice at a more appropriate time. So this is very exciting. Now, what happens when we start adding smart watch, smart home? I'm looking for nurse-developed apps. And are we preparing nurse innovators? And are we preparing nurses to use data in these ways for care and health system design towards the triple aim? So I would suggest that essential knowledge, and I believe at the baccalaureate level, and I'll share why shortly, includes care redesign, which includes identifying problems, identifying potential solutions, creating stakeholder buy-in, test the effectiveness of change, and then disseminating promising practices. And can we do all this, manage, understand the use of metrics, connections, and maximize impact while decreasing cost? Now, in these emerging models, are nurses demonstrating greater value than less expensive personnel? Perhaps not. The workforce researchers cited on this slide report that in case studies, MAs are acting in an array of roles that nurses and other health professionals once exclusively performed. Health coaches, motivational interviewing, screening for diabetes and smoking, foot checks, home visits, risk assessments, coordinating care, and providing patient referrals. And yet these same workforce researchers note that because there's 3 million of us, we are in the most pivotal position to drive change. But more attention needs to be given to identifying the competencies nurses need in these roles and providing the professional development. Now, I would differ in their last line when they say for nurses who wish to undertake these new roles. I think that the system is moving so rapidly towards payment reform that nurses will have no choice. And I'm going to talk about some of these models in which we now add accountability not only for outcomes, but for the cost of care. And I'll start with accountable care organizations, move to bundled payments, and then close with global budgets. So what is an accountable care organization? An ACO is a coalition of the willing. Is a group of providers who agree to be accountable for the cost and the outcomes of care. And if you look at the array of service sites and service types, it is really nurses that are prepared across this array and have a foundational skill set in most of these areas other than pharmacy and specialty care and ancillary providers. But the bulk of them really are central. Nurses are central to the care delivery. And you note here, population health is listed and data management as central. Now, I'm going to give you an example of the second iteration of ACOs, the shared savings, to illustrate how it works. And the shared savings is still on a fee-for-service shell. In a shared savings ACO, people see their primary care provider as they usually do. If the primary care provider belongs to an ACO, they accept responsibility for the cost and the outcomes of that care. They bill their provider in fee-for-service as usual. But the projected expenditures of that population, the panel population, is contrasted with the actual expenditure, risk-adjusted, because obviously ill people are more expensive to care for than well. And the difference is the basis of the shared savings, provided quality targets are met. In Medicaid, there is a federal match, and the savings are shared between the accountable care organization and the payer, being Medicare, Medicaid, or commercial insurance. Now, what if the actual expenditure is greater than projected expenditure? That's called downside risk, even though on that figure it would be a higher line, the downside risk. And by year 3, most ACOs must accept downside risk, which offers enormous pressure to create more efficient, coordinated models of care and avoid the most expensive forms of care, particularly when they're not providing value. Pioneer ACOs, many dropped out, some are still dropping out, yet the Wall Street Journal reports a study of independent actuaries that found nearly 4 million saved over 2 years. Most places are sort of in the middle of the shared savings program, and next-gen shared ACOs has just been recently announced, and this does allow risk sharing inclusive of fully capitated per member per month, meaning X amount of money for the provider organization per patient, regardless of how many or how few services are used. So again, enormous opportunities to think about nurse redesigned care and nurse-led programs. It does address limitations in previous models, for example, claims from home visits for non-homebound beneficiaries, which is very exciting because as an individual is transitioning to home from wherever they were, inpatient, long-term care, getting settled and really creating a workable life there is important. Telehealth outside of rural areas. So it really begins to address some of the limitations in the current system. Now, the next type I want to talk about is bundled payments. And oftentimes when I talk about bundled payments to groups of providers, some providers who have been directly reimbursed have a hard time understanding bundled payments. But nurses seem to understand it intuitively because nursing care has always been bundled into hospital charges. And so this is a bundle or a single payment, unlike unbundled care, which is fee-for-service, for the full episode of care. Why bundled payments? Well, 50% of Medicare spending results from 17 conditions, and I expect the bundled payment for joint replacement to be just the first of many. CMS initially tested 4 models, and this was with different kinds of diagnoses, not just joint replacement. And the findings to date have found the greatest variability in spending is actually in places nurses know best, skilled nursing care and home health agencies as well as rehab. And they found that the patterns of variation were condition-specific, and condition-specific delivery innovations are likely to be needed. This is a hot-off-the-press article, and who better to design condition-specific delivery innovations than nurses prepared along this full continuum. So these are sites where nursing care predominates, and yet are nurses grabbing the reins. Well, the authors I cite here say that physician leadership is crucial because they come up with the ideas, because they have skin in the game, and I agree that their ideas are critical and they do have skin in the game, but so do nurses. We have essential skills to bring, but may not know it. Bundle payments have been targeted to episodes of care, but could be targeted towards populations as an intermediary step between bundle payments and global budgets. Let me give you an example. Managing high cost chronicity. You're all familiar with the super utilizers. Usually they're using a lot of healthcare because they're very sick. 1% of the population of the United States is responsible for roughly 22% of the cost. In Medicaid, it's even more dramatic, 5%, 55% of the cost. But under traditional fee-for-service, there really isn't a disincentive for a lot of expensive treatment. Vermont's Chronic Care Collaborative is looking exactly at superutilizers. It is a team of nurses and social workers who do individual and population health management. It looks like a very high-touch program, and it is, but it actually depends on very complicated analytics to identify which patients are at risk, which populations are at risk, and intervene. It is a care-based, not a cure-based model, and exactly what we need is all the baby boomers are moving into old age. So here are the types of services, assistance with housing, transportation, learning how to talk to providers and plan care. Individuals with complex health situations receive face-to-face case management. Those at lower risk receive health education or coaching by phone, but the goal is for all of the participants to manage their lives as well as their health conditions. What's very exciting is that although this is a very expensive program, it has been very effective in saving money, reducing inpatient utilization, emergency department, and decreasing 30-day readmission. And what I find most exciting about this data is that you can see that the teams are just getting better and better at what they do. They're starting to understand how to use the analytics better, how to reach across the population, et cetera. Now, the most bundled services, for lack of a better word, is a global budget. And why would any hospital or state consider a global budget? Well, the need to move away from fee-for-service for a more comprehensive cost control mechanism, but it also enables the community to align what it does with the needs of the community and prevents the chasing of revenue that happens in fee-for-service. Let me give you an example. At our recent hospital budget hearings, one of these small hospitals is very interested in doing more with addiction services, and they do have a new provider there who's working with that population, but they would really like to expand the services because it's a crisis in that area. But in the fee-for-service world we live in, that's the money loser, and they are in a position of really, in essence, chasing revenue from orthopedics and imaging and other kinds of things, services that could be received at a facility that's very close. And so if that hospital had a global budget, they could really think about what they wanted to do to serve that community in a very holistic way. And like a household budget, the hospital has a strong incentive to reduce unnecessary care. So Maryland has, and some of you may be from Maryland, they have a hospital global budget. And the outcomes to date, just reported on November 12th, is that they moved 90% of the hospital revenue away from fee-for-service to global budgets more quickly than expected. And they had agreed to save Medicare $333 million by 2019, and they're already a third of the way there. Now, they have a list of all kinds of outcomes, and everything looked very good in the outcomes, with the exception of the potentially preventable condition of catheter-related urinary tract infections, which is something that needs to be unpacked, but is certainly disconcerting given that it is one of the few nurse-sensitive indicators that was on the published list, and I invite you to take a look at that article. So Maryland is doing it for hospital budgets, but Vermont is proposing to do it for all of healthcare that is what's currently under Part A and Part B services. So hospitals, nurse practitioners, physicians, health centers, other providers, all payer, Medicare, Medicaid, commercial insurance, and self-insurance. And the hospital, the state take accountability of total cost of care. And we are currently in negotiations with the Centers for Medicare and Medicaid to be able to do this because it would require a Medicare waiver. And this particular initiative would be overseen by the Green Mountain Care Board. So how different are these global budgets really? Well, fee-for-service creates, in fee-for-service, hospitalization creates revenue for the provider organization. In a global budget, hospitalization is a revenue drain. In fee-for-service, intensive, expensive, high-tech interventions generate the most income. In global budgets, it's exactly the opposite. It zaps revenue. So how big of a change is this? What does it mean to nurses, nursing education, nursing administration, policymakers when we start to celebrate empty beds rather than hospital beds, instead of full hospital beds? Potentially, I'm optimistic that it creates incentives for integration of not only mental health but behavioral health, understanding, why the person is drinking too much, getting an intervention in place, thinking about depression, really thinking about social determinants of health. If an individual is homeless and you're responsible for the total cost of their care, sending them home with the notion that they'll come back in the emergency room if need be is really not going to be acceptable. So housing becomes a critical part of health care. Having discretionary financial resources to address things like transportation, for example, calling Uber to get somebody to their appointment or whatever is getting in the way of optimizing the individual's life and their health. And from my perspective, it incentivizes the appropriate use of what we call complementary and alternative. In many ways, some of this is complementary and alternative because it's outside of traditional fee-for-service and traditional mainstream. There is quite a body of knowledge, for example, supporting the use of acupuncture for chronic pain. And in these kind of models where you're accountable for total cost of care, this type of intervention there's a lot of incentive to think about care coordination and the most appropriate, least invasive sorts of support to keep people healthy. So what do nurses need to know? Obviously, the metrics on which cost and quality are measured. We need to know how to propose and test delivery models that contribute to individual well-being and decrease cost. We need to know how to mobilize resources, both financial and social and community, to serve individuals. It should actually say people, not patients, because we're trying to keep them from being patients. And we need to know how to transition from a fee-for-service model in which people are turned into patients to a more comprehensive person-centered model. So the researchers I mentioned earlier talk about these skills: care coordination, care process reengineering, dissemination of best practices, team-based care, continuous quality improvement, use of data. I would add understanding the underlying financing and payment incentives and quality metrics, even though quality science is still in evolution and there's at least some question about metric-driven harm, metric-driven over-treatment, over-screening. But quality science will get to the point where we really have more accurate measures of well-being. I wanted to mention briefly group office visits, shared medical appointments, because I think this is an ideal skill set for baccalaureate prepared nurses. According to the authors I have listed there, these sorts of shared appointments are well received by individuals with chronic conditions and work very well for education as well as enhancement of life management skills. So if it's a group of individuals with JME, juvenile myoclonic epilepsy, perhaps a bunch of adolescents sitting and talking with other adolescents, how they're managing the issue of epilepsy, how it feels to have a seizure in the classroom. There is something very positive about that type of intervention. Obviously, individuals have to agree to be wanting to be part of a group, but this is a perfect skill set for nurses to facilitate, and I don't believe you need to be an advanced practice nurse to be able to do this. So Einstein famously said, when we discovered atomic energy, everything has changed but the way we think. And nothing at all note that the use of one of the first models we talked about, patient-centered medical homes, has been limited by physician-centric models with unimaginative use of PAs and NPs. I would suggest we've also had unimaginative use of nurses and other providers. Now, the AACN Essentials of Baccalaureate Education, these are just four of many. But you note that we believe that we have prepared our students to describe how healthcare is organized and financed, to be able to compare the benefits and limitations of major forms of reimbursement on the delivery of care. But I believe that these skills, this knowledge, skills, and experience is foundational and needs to start in the very beginning of undergraduate nursing programs, because nurses are prepared as generalists and across settings, yet I would ask myself as a faculty and my faculty peers around the country, are we systematically preparing students in these new skills and these foundational skills that are very consistent with a nursing model of holistic person-centered care? And what does this mean for associate degree education that has focused more directly on inpatient and long-term care? So all of us have been marinated in episodic fee-for-service, and my office is right outside a sim lab, and there's lots of practice and all these high-tech interventions. But what about simulated care redesign experiences? What about simulated experiences in practicing watchful waiting? A notion that I'm very enchanted with is called real cost accounting. It's from ecological economics. And it says that instead of looking at that cheap hamburger, we have to think about the cost of the rainforest that was cut down for the cattle, and then the shipping of it, and then if it's in a styrofoam container, the impact on the environment. So too, what is the real cost of what we do as nurses, and what's the real value? And I think if we can move to more real cost accounting in healthcare, what's the real impact? The value of nursing will become more and more clear and more predominant. And then finally, I think I'd like to see us having more skill development in living with the ambiguity that a change agenda requires, because change requires living with a lot of ambiguity, and we really socialize ourselves and our students to think there's a right answer, one way to do it, the correct circle on the bubble piece. We've had little accountability beyond the person right in front of us at the time, and little questioning of the underlying assumptions of care, little deep discussion of the issues of overscreening, overtreatment, and overutilization, and what we as nurses can do about it. And finally, I would just like to say that from my perspective, although we talk a lot about interprofessional education, team-based care is a strategy towards the triple aim, not a goal in and of itself. And you see that most of these models I've described do require a lot of interaction, and really a team approach seems most appropriate. However, team-based care has interaction costs and transaction costs, and sometimes the most appropriate care is an individual. And so this idea of teamness is still in a concept in evolution. We're challenged, of course, because people have lives, but we have disciplines, and we're really now trying to configure ourselves to really work in these new models that are much more holistic in what they're trying to do. So to close with Einstein, we can't solve our problems by using the same kind of thinking that we used when we created them, and I would suggest we need to move very rapidly to helping nurses at all levels of their career think about what it means to be in these new models in which we're accountable for the cost and outcomes of care. And I'd love to hear your thoughts, your questions, your suggestions.
Great. Thank you so much, Betty. That was a really good presentation, full of lots of information, and I'm sure we're going to have lots of questions. So at this point, if you'll move over to the questions area of the toolbar, you can send over your questions, and traditionally I like to have Pete ask the first question, so I will let him do the honor of having the first one if he is ready. Pete?
Oh, thanks, Christine. Thank you very much, Betty. I've got 6 questions that I've written down, so I'll get us going. And I really can't pick which question I want to ask first, because they're all, I think I would like to hear Betty's answers. So I'll just start with one that's maybe a little weird, a little wacky, which is, Betty, you've convinced me with the questions and towards the end of your presentation, we've really got to work fast and decisively to get the current workforce up to speed, let alone the burgeoning numbers of new people who are becoming nurses, large numbers in our education programs, to get them ready for a value-based world. And given that, do you think it's time or appropriate to have some sort of a national summit on bringing the leadership of the profession, education, practice, research, policy together to focus in on value? And
well, I think we have to work at, what's that?
Go ahead.
Well, I think we need to work at every possible level. I think we need to work in a national summit is great. I think we need to work at the working surface. Let me give you just an example. I teach, our RNWS program has a health, finance, policy, and economics course that I teach, and of course this material is central to it. And I hear from these RNs that are coming back, all smart, successful women and men, mostly women and men. They are stunned at what's been happening in their workplace, and were really unable to understand what was happening. One person said, oh, I understand now the readmission thing. We were just told that we should give 2 forms of discharge summary or discharge planning, not just one. And so it's just another task that doesn't have any context. And so I think often of the saying of the 3 people laying brick, one's laying brick, one's building a wall, and the third is building a cathedral. We have to help nurses at all levels understand what's happening, because then it makes sense, and there's so many ways we can participate. So I think a national summit, I would like to see this content be much more strongly developed in undergraduate and graduate curricula, and there's a lot to do. So yes, national summit would be great.
Thank you.
Okay, Betty, we've got one question from the audience here. Has the metric-induced harm the concept of underutilization been considered? For example, the incentives to save on decreased MRI exams?
Yeah, it's a really complicated question and study, and I have been doing some studying of the issue of metric-induced harm, where the providers end up unwittingly treating the metric rather than the individual. And because public reporting of outcome metrics had been has been existing and longer in Europe, there's more developed thoughts about this. But this whole issue of treating the metric rather than treating the individual is one that I'm concerned about. In terms of overtreatment versus undertreatment, we are a paradox of overtreatment and undertreatment in this nation, and much of the overtreatment is driven by a fee-for-service, and that's my opinion, but there's also a fair amount of documentation. But if you look at our outcomes in the United States, we are much more resource intensive, and yet the most recent list of outcomes, that was the Commonwealth, 11 developed nations, we were number 11. And so, frankly, I personally am less concerned about undertreatment than overtreatment. It is different than the HMO days because we now have pretty sophisticated sets of analytics, and they're becoming more sophisticated all the time. So I am less concerned about that. I mean, one of the things I think we won't have is the chasing of certain kinds of things. For example, I get a notice all the time about a certain kind of imaging thing reminding me to come in, and it's actually not something I need. I look very carefully at the data, and I don't need it. So I think some of that will stop. But I think we'll have to be attentive to this issue of overtreatment and undertreatment and trying to.
Great, that's a good point. I have one other question here. It's about jobs. So do you think preparing new RN graduates to understand value-based care models of delivery will help them become employed? How can we change the thinking that new RNs cannot work in these new roles and practice areas such as clinics, home care, hospice, care coordination? Workforce is aging in these areas more rapidly than inpatient, and fewer new grads being hired into hospitals. These areas should provide increased jobs with value-based care for RNs, and how do we address this?
Yeah, it's a great question, and I think that there really has been a hospital-centric mindset in nursing education, and maybe that was appropriate when that was the bulk of the job. But there always has been this notion, and I still hear it sometimes from families who are looking at programs, when does the student start on the floor and that type of thing. I'm very concerned that we are not taking the bull by the horns and showing the value that we can have in transforming care in these other settings. And we've had the situation here in Vermont, because Vermont is moving very, very rapidly away from fee-for-service, and in fact it was passed in a law a few years back. It's the law that created Act 48 and the Green Mountain Care Board. One of the chief nursing officers went to a bunch of the nurses in ICU and said, look, you're the best nurses I've ever had, and you're going to be dinosaurs because this book of business is shrinking, and I want you to become transitional care nurses. And they were outraged and all of this, and then they did it, and now they love it. But that chief nursing officer was seeing what was coming. So I think that faculty largely control the curricula, and we all largely prepare people in the model that we were socialized in ourselves. And it's very difficult to make some of these changes, and I think it will come from the service side. And as you saw on the one slide, unfortunately, if nurses don't grab the opportunities that they have to create value, other people will be there to fill our spots, particularly some who are less expensive than nurses.
Thank you. That's excellent points. One more question here, or maybe perhaps a comment for you to comment on. It is so important to start changing the value of nursing as an asset in cost savings rather than the nursing being seen as strictly as an expense to the bottom line. Getting nurses into the financial discussion at tables of decision making is key. We need to teach nurses to be negotiators at these tables and bring the economic value of nurses to those who make the decisions on staffing. You have thoughts on that question or comment?
Yeah, that's a great comment as well. And one of the things that's most exciting to me about things like global budgets is that in a fee-for-service world, physician and hospital care is seen as a revenue generator, whereas nursing is seen as a labor cost. And in these new models of care, everything's a cost. Everything's a labor cost. So one of my colleagues on the board who's leading payment reform is a former hospital administrator, and I asked him how he sees what this looks like, and he says, as a hospital administrator in the old world, I see a full emergency room and I'm happy. As a hospital administrator in this world, I see a full emergency room and I'm worried. So I think that the real opportunity is that, in a sense, it puts all of us on the same footing, is because we're all, in a sense, now a cost. And so the opportunity nursing has with our holistic view, our ability to, our preparation across different settings and sites, to really be essential in the coordination of these new models. But without being able to speak about the money and understand what's driving some of this, I think it's very hard for nurses to be able to really to feel confident that they know how to be part of the conversation.
Thank you. Very true. Okay, so I have one more question, and I'll let Pete tackle one of his 5 remaining. Any country in particular that is producing good data on the utilization? I am here in Serbia from this asker. So do you know of anybody who's producing good utilization data?
Boy, that's a great question. Utilization of healthcare services, is that the question? Because a number of the Commonwealth report that was just out does have a variety of different kinds of metrics that they explored with coming to their rankings. And, you know, the cultures are also very different in terms of their approach to care and what seems normal in terms of reflecting, in a sense, the values of the culture. I can speak with first-hand experience. My daughter had a health incident when she was studying in Germany. She was hospitalized for a month. And she would have never been hospitalized for a month in the United States, but people also, it was in a country setting, people went out in the middle of the day, walk around. It was a very different approach to care. So it can be difficult to do direct comparisons because health systems are so different. I think about the Netherlands and their dementia villages, very different kind of approach to the management of cognitive impairment. So I don't have at my fingertips a direct a direct place to direct this individual, and thank you for calling in from far away. But there is data that does international comparisons, and I'd recommend looking at the Commonwealth report.
Great, thank you for that resource. Okay, Peter, I'm going to let you ask another one of your questions over to Montana.
All right, thanks, Christy. Betty, you said in the very beginning of your presentation, what is paid for grows and what is not paid for withers. And I sort of want to use that as the starting point. And what I'm most concerned about is that as we move into more value-based care and payment, and we move more into ACOs, where we get more into the social aspects of care versus the medical care, will these services be paid for? Because today it seems most of the payment by Medicare, Medicaid is a sort of a traditional medical procedures and this and that, and it's medical. But if you go out and ask patients and people what healthcare means to them, it's not about rehospitalization or a lot of this stuff. It's a whole different set of things that go into healthcare. And if we don't pay for understanding what is meaningful to the population we're serving, we'll miss, I'm afraid, we'll miss providing good health care, but we'll pay for a lot of other stuff on the medical side. And so I don't know if you agree with that, but are you worried about that? Is that a concern?
Well, I think it's a great observation, and I can tell you from my experience at the board oversees hospital budgets in the state of Vermont. We did have a hospital ask, we set their budgets, they asked for basically a discretionary pot of money so that they could use it, for example, to buy an air conditioner for children, a child who keeps coming in with particulate-induced asthma, etc. But in global budgets, remember, the hospital or the health system, if it's a statewide ACO, as it may be in the state of Vermont, they are going to get X amount of money for the population, and then it can be used however they choose. And in those kind of models, the hospitalization is the most expensive route to go. So we are finding, and I know a new ACO in Rhode Island was also thinking about, we need this discretionary pot of money because people have lives and we have, diagnoses, and the two don't line up in a sense. So that is the real potential opportunity if we can really make this social transformation. And if those who really understand issues of social determinants of health are really at the table shaping this as it moves forward. So it's potentially a very exciting time, and also potentially precarious time.
Great, thank you, Betty. One more, probably for your comment. This is not only important to educate nurses about value-based payment models and to educate them about these new roles that are coming, we must also develop venues within organizations where they can voice their opinions and knowledge, and getting nurses on boards and councils will be key. Do you have any comment on that piece?
Well, thank you. We did have a small grant here in the state for getting nurses on board that I'm going to have to do. I have written a book really targeted towards undergraduate students that has the information on financing, payment, financing being how money goes into the bucket, payment reform, ethics, economics, the intersection of ethics and economics, but then it really concludes with a primer on boards to have nurses understand that they can and should aspire, and to how you develop those skills and how you also develop skills in the policy arena. And I think we as nurses have traditionally thought of ourselves really as interpersonal providers. And I mean, most of us didn't become a nurse because we want to stand on a board or because we wanted to run for office. But the more we can model this as essential skills to serve society, the better society will be. So I think having this conversation, let the most trusted be the trustee, is exactly right, because most hospital boards are at least fairly well populated with physicians and community leaders, and nurses are still markedly underrepresented on hospital boards, even though they're the largest workforce within that. So there's a lot to do there, and I absolutely agree.
Okay, we've got maybe 2 minutes left. Pete, I'm going to let you close us out. If you have something you think that you'd love to hear about in the last 2 minutes, and then we'll call it a wrap on this great presentation.
I'd just like to say thank you, Betty. I think you've really hit a number of key issues. I think this is an outstanding presentation. I'm very interested in taking a look at your book, so I'll be in touch, and maybe we'll be able to get some information on our website about that, Betty.
Great. Yeah. It's really, I think it's foundational that nurses can not only speak clinically, but speak with the language of power, and that includes finances.
Exactly. And lastly, don't get worried, don't give up. You'll see some snow coming your way soon.
I'm sure I will, absolutely.
Thanks again.
Thank you all. Thank you for listening, and I appreciate it very much.
Great, thank you all, and this will conclude our webinar today. And thank you so much to Betty again, our presenter, and then thank you all for our attendance. Our next webinar is set for early December and will be announced soon. Stay tuned to the website and email announcements for more details. And everyone, have a happy Thanksgiving.